Okay, great. Good to see you. Thank you for joining. Welcome, colleagues, and very big thank you to all of you for making the time and joining the session and making time to be part of this conversation today. Before we begin, I do want to acknowledge the circumstances in which we meet. It's been quite a journey for some of us, getting to Geneva, but also probably symbolic of the moment that we are finding ourselves in. We're meeting at a time where discussions on human rights are becoming increasingly contested. Around the world, we're witnessing growing attacks on civic space, democratic participation, and fundamental freedoms. And we're navigating the impacts of conflict, economic stability, climate crises, and the rise of authoritarian tendencies that seek to undermine hard-won gains and freedoms. At the same time, many of us are grappling with deeper questions about power, inequality, and the systems that continue to produce exclusion and injustice. So while the timing of this discussion is always right, it also comes at a time where we are seeing really increasing forms of crisis. And this is probably why this conversation is important. And in moments like these, coming together like we have to think collectively, to strategize, and to strengthen solidarity becomes much, much more important. So welcome to the session, and I look forward to our discussions today. For those I have not met yet, my name is Nomtika Mjwana, and I lead the Human Rights, Racial, and Gender Justice Strategic Priority at Frontline AIDS. And I am happy to also introduce my friend who plays a huge role in getting us organized for the session, Patty Lawrence. And we are joined by some of our colleagues and other comrades and partners online. So welcome to everyone. Before we start, I'm just going to give a quick summary about Frontline AIDS, as we've recently launched a new organizational strategy that places a strong emphasis on building resilient health systems. We also understand that we are at a time where anti-rights attacks are increasing, and so we've got a core part of our work that focuses on the rights, addressing the rights barriers that prevent people from accessing healthcare and confronting the actors and structures that perpetuate exclusion and discrimination. But importantly, as I've reflected, as conflict, displacement, political instability, and climate-related emergencies continue to shape our world, we also have made responding to HIV and health needs in times of crisis as our strategic priority. So human rights are quite central to our work. Some of you may be aware that Frontline AIDS works on two flagship human rights programs, one being the Rapid Response Fund, that focuses on responding to emergency situations and requests from communities and human rights defenders at community level. We also have REACT, which is Rights, Evidence, and Action, which is a human rights monitoring and documentation and response tool that generates community-led evidence about human rights violations. And at a time of shrinking funding, increased attacks on rights, and mounting pressure on community responses, there's an urgent need to strengthen collective thinking, movement building, and action that's truly accountable to the communities who are most affected. It is therefore an absolute privilege convening this session, and it is my absolute honor to welcome our panelists today. We are joined, before we go there, sorry, I also wanted to quickly acknowledge our colleagues and co-sponsors for the session. It would not have been possible without the support from the Association for Women's Rights and Development. We know them as AWID. We've got our colleagues and friends from Choice and Youth Sexuality, and we've also got the Global Action for Trans Equality that we know as our friends at GATE. And through GATE, I also wanted to extend our appreciation to the STAG initiative for their partnership and support in bringing this discussion together. So thank you all for your collaboration. I also want to take a special moment in this time because we are having Dr. Tlaleng Mofokeng, who concludes her mandate as the United Nations Special Rapporteur on the Right to Health. Your mandate, Dr. T, has been marked by courage, clarity, and unwavering commitment to centering dignity, justice, and lived realities in global health discussions. And on a personal level, as a young South African activist, when I met you, I'm not young anymore, I am deeply grateful to be standing on the shoulders of a generation of resilient and visionary activists who've shaped our country's human rights legacy, and I'm grateful to have known you and to know that you are one of them. South Africa's history does remind us that rights are never gifted, they are fought for. We're here today, June 16, on a public holiday from South Africa that looks at Soweto uprising, where young people took to the streets to be their own human rights defenders, fighting against a language of the oppressor. And this was 50 years ago today. And so we've recently seen this also, and the power of civil society from and in South Africa, from accessing treatment and really strong advocacy for strengthening health systems. And so I wanted to take a warm, good time to acknowledge the launch of the Lena Kapavir in South Africa, but also strongly the principled stance that they took at the Interparliamentary Conference on Family Values, where they affirmed that discrimination and exclusion have no place in societies that are committed to dignity, equity, and human rights. And these are examples that remind us that leadership that is grounded in human rights remains both possible and necessary. It is therefore my pleasure to introduce my fantastic panel. We are joined by Dr. Tlaleng Mofokeng, of course, who's the United Nations Special Rapporteur on the Right to Health. Welcome, Dr. T. We are joined by Alexandrina Iovita from the Global Fund, who is the Senior Technical Advisor for Human Rights under the Community Rights and Gender Department. Welcome, Alexandrina. We are also joined by Kelsey Brooks from the STAG Initiative in Nigeria, which is a feminist-led organization that supports underserved youth, including women, transgender and intersex persons, and their work is grounded on advocacy, education, and empowerment. Did I do you justice? Welcome to the panel, Kelsey. And we also have joining us virtually our dear friend and good colleague, Umira Ahmad from AWID. Thank you for joining, Umira. Umira is the advocacy lead for advancing universal rights and justice at AWID. Hi, Umira, thank you so much for joining. So thank you all for lending your expertise, experience, and perspective for today's discussion. We'll bring our collective knowledge, and an important question will be addressed today. How do we strengthen and support defenders of the right to health, but overall human rights defenders and community-led movement at national, regional, and global levels? And how do we ensure that this protection, solidarity, and resourcing remains available on the front lines of advancing human rights in an increasingly difficult time? So just a quick one on the flow of today's session as we're about to start. We will do a brief intervention from each of our panelists for about 7 to 10 minutes with some guiding questions. And then we will have some time for floor interventions and discussions. And maybe Paddy will keep an eye on online as well, should there be any engagement. And then we will do some closing remarks and finish. We really only have an hour. This is a very important discussion. And so we do not necessarily have a lot of time. I encourage us to be present. I encourage us to feel that this is a space where we can all engage. And without any further ado, we shall begin. Are we all feeling okay? Great. Okay, I feel like I've been saying a lot. So we will start with you, Kelsey. You bring a great perspective, country perspective, national perspective. And I wanted to find out from you, what are the biggest gaps and challenges that's created by criminalization and anti-gender attacks for access to HIV prevention, treatment, and the right to health? And on the back of that, in your intervention, you can also add any ways or learnings we can get on how human rights defenders have been supported and protected to continue defending the right to health and justice. Thank you. Over to you.
Okay, thank you so much, and good afternoon, everyone. And thank you to the Frontline aides for this space and for the years of investment in community-led human rights responses through mechanisms such as the REACT and the Rapid Response Fund. So I speak from Nigeria as a trans person, as a community organizer, and someone whose work sits very close to the point where health, law, violence, and survival meet. In my context, the right to health is not only about whether HIV services exist, it is about whether people can reach those services safely. For many trans and gender diverse persons like myself, the question is not only, is there a clinic? The question is, can I enter that clinic without being exposed? Will I be treated with dignity? Will my identity remain confidential? Will I be mocked, misgendered, reported, or denied care? Criminalization and anti-gender attacks create 3 major gaps in HIV prevention, treatment, and the right to health. The first gap is fear. Fear keeps people away from HIV testing. It keeps people away from PrEP. It stops people and defenders from reporting violence. It makes people delay treatment. It makes people collect medication irregularly or through informal routes. When a person believes that their identity can be used against them, even a health facility can become a place of risk. The second gap is invisibility. In my country, this is not theoretical. Trans persons have been removed from the ongoing IBBSS protocol. The Integrated Biological and Behavioral Surveillance Survey is one of the tools used to understand HIV burden, access, risk, and service needs among key populations. At the same time, in a national assessment on public health facility use and accessibility, trans persons were subsumed under the MSM category. This may sound like logical technical decisions, but they are not small technical decisions. They are not equitable, defeating a core foundation of public health. They determine who is counted, who is funded, who is planned for, and who is left behind. When trans women, trans men, and gender diverse people are erased from data systems or absorbed into categories that do not reflect their realities, our needs disappear from the evidence. Then they disappear from budgets, guidelines, commodities, training, and services. You cannot save a population you refuse to clearly see. You cannot defend what is not seen. The third gap is interruption of care through violence. Criminalization does not remain inside legal context or text or papers or books. It enters homes, clinics, police stations, schools, workplace, social media, families, communities. One incidence of violence can affect every part of health. When a person is attacked or evicted, they miss clinic appointments, their mental health suffers, they stop seeking care because survival has become the first emergency. So in our context, protection and HIV access cannot be separated. And across Africa, we have also seen positive examples of what protection can look like when it is sustainably resourced and community-led. In Eastern Africa, we have also seen positive examples of what protection can do, where anti-LGBTQI laws and anti-gender mobilization have intensified in recent years across the region. Community organizations have used emergency grants, legal referral networks, safe relocation support, and rapid documentation to keep HIV work going, even when public visibility becomes dangerous. In some contexts, defenders have had to move from open advocacy to quieter models of accompaniment, helping people reach services safely, supporting emergency shelter, documenting violations, and maintaining confidential referral pathways with trusted health providers. In Southern Africa, community-led monitoring has shown how communities can turn evidence into accountability. When people living with HIV, when sex workers, LGBTQI people, people who use and inject drugs, and other key populations document stockout, stigma, denial of care, police abuse, or breaches of confidentiality, that evidence can be taken back to health facilities, district health teams, national AIDS councils, and donors. This is one way defenders are protected, not by leaving them alone with risk, but by turning their experience into recognized evidence that institutions must respond to. In West and Central Africa, where specific space is often fragile and criminalization remains a major barrier, rapid response support has helped organizations respond to raids, arrests, blackmail, eviction, denial of services, and threats against community workers. This kind of support matters because it allows defenders to act quickly before a health crisis becomes a legal crisis and before a legal crisis becomes a life crisis. This is why Frontline AIDS investment in mechanisms like REACT and the Rapid Response Fund is of great importance for communities. These approaches recognize that communities and community organizations are not only advocacy actors. We are first responders. We document violations. We connect people to services. We support access to justice, generate evidence that can influence policy and funding decisions. And trans communities across the globe embodies these responsibilities. In addition to resisting anti-gender attacks and rapidly emerging binary laws and shrinking civic spaces. The Global Fund has also shown through its human rights and community system investments that removing human rights related barriers is not a side issue in the HIV response. Legal literacy, access to legal services, stigma reduction, non-discriminatory healthcare, better law enforcement practices, and community-led monitoring are all part of what makes HIV prevention and treatment reachable for people most affected. In Nigeria, this lesson is very clear. When trans people are attacked, evicted, outed, denied care, or pushed out of national data systems, community defenders often become the only standing bridge between survival and health, however underfunded that infrastructure is. As TAG Initiative, a trans-led crisis response organization in Nigeria, where I have the opportunity to serve as the executive and creative director, protection has meant helping people, helping trans people, LGBTQI people, survivors of anti-gender and anti-right attacks find temporal safety, linking them directly and discreetly to HIV and SRHR services, supporting legal and psychosocial referrals, documenting these violations and abuses, and following up so that people do not fall out of care, despite severe funding limitations and restrictions. Yes, these examples are positive, but they are not enough on their own. They show what works, but they also show what is still missing and what could be done to ensure we achieve the global 2030 goals while ensuring trans people and other key populations, sex workers, people who use and inject drugs, men who have sex with men, people in closed settings, and others are not left behind. Protection cannot depend only on short-term emergency grants, personal sacrifice, or the courage and brevity of a few defenders. It must become part of national HIV systems, donor strategies, and UN-level accountability. So the question is no longer whether community-led protection works. We have evidence that it does. The question now is whether member states, donors, and multilateral institutions are willing to fund it, formalize it, and protect the people who deliver it. First, member states must recognize community-led protection as part of the HIV response, not as separate human rights work. And when I say community, I mean all communities, trans communities, key population communities, and others. When violence interrupts treatment, protection of these communities should become treatment support. Second, states and health institutions must fix the data problem. Each community must be counted. This does not mean unsafe or careless data collection. It means ethical, confidential, community-designed data systems that protect people while making their health needs visible and as such addressable. At the UN level, we need stronger guidance that tells countries clearly key population data must not erase trans people. This data must not collapse distinct populations into categories that are convenient for institutions, but harmful for these communities. Disaggregated data is a necessary condition for equitable HIV planning. Thirdly, donors and multilateral institutions must invest in rapid response mechanism with flexible funding. Community organizations are often the first to respond when someone is attacked, outed, denied care, arrested, or displaced. For many trans organizations around the globe, we arrange transport, we connect people to clinics, we find temporary shelter, we support documentation, we link people to legal aid, we help them stay on treatment. But too often, our work is funded in small, restricted, short-term ways, limiting our impact and reach. The funding should be flexible enough to cover transport, temporary shelter, legal support, emergency communication, psychosocial care, digital safety, and documentation. This is where mechanisms like REACT and the Rapid Response Fund are important. They show that when communities are trusted, resourced, and equipped, they can document violations, respond quickly, and generate evidence for advocacy. But permit me to use this opportunity as we celebrate Trans Advocacy Week to ask that these mechanisms take a keen interest on trans organizations and groups in criminalized context who are not only doing all this, but are having to combat anti-gender attacks and rapidly encroaching legal instruments that makes even defending the right to health difficult. This directly fits into my fourth recommendation that human rights defenders need protection before a crisis happens, not only when crisis happens. For the fifth recommendation, governments should create formal referral pathways between community-led organizations and public institutions. In Nigeria, this is one of the lessons we have learned from our work as TAG Initiative, and it's that protection works better when community responders are not left alone. For the sixth, health workers must be trained and held accountable. Many people are not excluded from care because there is no clinic. They are excluded because of how they are treated inside the clinic. And this treatment is made possible by the laws existing in such context. Member states should invest in stigma-free, rights-based, gender-affirming training for health workers. But training alone is not enough. There must be complaint system, confidential protection, service standards, and consequences for denial of care, outing, abuse, or humiliation. This shouldn't just be another checkbox in a report. For the seventh recommendation, anti-gender attacks must be treated as a threat to public health. These attacks are often presented as moral debates or cultural debates, but their effects are public health crises. They reduce service uptake, they increase fear, they weaken community organizations, they spread misinformation, they make HIV prevention and treatment harder. So our response must also be a public health response. UN agencies, member states, and donors should track anti-gender attacks as part of the risk environment affecting HIV outcomes and human rights. Finally, we need to move from symbolic inclusion to shared power. Communities should not only be invited to validate decisions or reports or evidence after they have been generated or made, as such has been the case. Trans people, sex workers, LGBTQI people, people living with HIV, and other marginalized groups must be part of designing policies, surveys, indicators, budgets, and accountability systems from the very beginning. In Nigeria, we have learned that when someone is attacked, the real questions are very practical. Where would they sleep tonight? How would they continue their HIV medication? Who can take them safely to care? Who can document what happened without putting them at greater risk? Who will follow up after emergency? This is what community-led response does. It keeps health reachable when the formal systems become dangerous. So my message to everyone seated is simple. Do not erase us from data. Do not separate health from protection. Do not ask communities to carry emergency response without emergency funding. Do not wait until defenders are harmed before protecting them. Because if we are serious about ending AIDS and protecting the right to health, then we must collectively protect the people who make health possible for those pushed furthest from the system. I believe and hope my message has been clear and look forward to future changes. On behalf of the community, thank you again for this opportunity.
Incredible. Thank you so much, Kelsey. There's so much that I've taken from this. I think one thing that stood out is the point about protection and HIV access cannot be separated. We do not access hospitals because they are not there. It's because people do not want to face any kind of violence. And the reflection on emergency responses as well. We're the first line of responders and the last line of defense. Everything will always have to be around that. And so sustainability, the point that you made about that is another critical one around us sustaining the response. I don't want to do too much reflection because we do not have a lot of time left, but this ties nicely to health as an enabler of dignity, which is Dr. T's report that will be shared with us tomorrow with an interactive dialogue. Dr. T, I don't want to say what trends. I think you've given us enough trends with all the reports and you've given us all the evidence. But I really wanted to ask, what are the unspoken trends that you're seeing in the backlash, particularly with the role that you've held against human rights and health justice? And what does this mean for the realization of human rights globally? And on the back of that, with having been in this position and interacted across community, regional, national, global level, what should international actors, including donors, multilaterals, and governments, including us, CSOs, be doing differently to protect human rights defenders and advance the right to health? Over to you, ma'am.
Did you just call me Mama? The gray hairs are a proof that's really appropriate. Thank you very much, Nomtika. And I want to say that I, of course, have been focused on many thematic reports in the last 6 years. But speaking about the right to health and defenders of the right to health, I want to spotlight the role that health and care workers play in realization of the right to health, but exactly on what you were just saying: availability, accessibility, acceptability, and quality of care. No matter who comes or doesn't come, healthcare workers are placed in those localities where services need to be happening, where human rights need to be beyond just abstract aspirations, need to be tangible, but importantly, the centering of dignity as an actual outcome that can be measured. We have to resist this idea that dignified care is just subjective and is not, scientific enough. On your question about what we need to look out for in terms of emerging things, maybe I'll answer it in a way that says what I wish I still had time to do. What I still wish I had, maybe if I had more time, is to look at issues of disability and the right to health, both visible but also invisible disabilities, which is also different from rare diseases, There's a particular nuance that comes with understanding how even architectural design can be racist, can be ableist, can be transphobic, can be anti-immigration and anti-homelessness, for example. So I wish I still had time to analyze from a right to health perspective how those kinds of structural violences also, mean for the right to health. But in the report on violence and racism, I kind of alluded to how even social spaces themselves determine who is heard and who's not heard. And so you will see in my reports, I never used language like unseen or weak, vulnerable people. Is that systems decide who is made vulnerable. Systems decide who is allowed to die and who is killed, for example. And so when it comes to health and care workers, Nomtika, I decided last year to do a report to the Human Rights Council and one to the General Assembly, basically locating health and care workers as human rights defenders, because we understand and we need to understand that their healthy working environment that is just and fair, it's a healthy healing environment for patients that is also just and fair. And you can't have one and not the other. And so when we are looking at the ways in which health and care workers are critical to realize and defend the right to health, we then have to talk about the deeply intertwined nature of the social fabric. And that, of course, health and care workers are the backbone of health. Remember, during COVID, everyone was clapping. And you're all like, no, don't clap for us. There's a lot that's going on here that needs everyone's attention. And many of us started doing that advocacy work again, on the equity around vaccines, up to where we were calling it even the vaccine apartheid, right? People are saying, but that's so harsh. And when you saw how capitalism and extractive capitalism made the right to health a profit-making scheme, even in the worst disaster of our human experience collectively, you could see then why those words were so important. And health and care workers, whether it's preventative care, whether it's curative, palliative care, whether it's in the communities or on an individual basis, they continue to be uniquely positioned to act as catalysts for health equity. And we ought to have more doctors, nurses, clinicians at decision-making platforms at the local level, at the national level, at regional levels, at global levels. I often get a question, with all of the money that global health has put into all of these different programs around the world, why have we not yielded the results and the outcomes that we expect, right? People are looking at indicators. I said, well, you are not asking the people what kind of help they need and what's urgent for them, right? You design programs in the global north, which is the world's minority, and you think you can just come with these pre-designed prototypes that you think are important with indicators that you have decided are important, and then just implement that in the so-called global south, but really the global majority. And so we have to see the interconnected nature then and the structural nature of what we are dealing with. But we can't talk about health and care workers. We can't talk about just even the idea of having people who are the defenders of the right to health and not talk about protracted war, not talk about conflict, not talk about the genocide, because all of those are incompatible with the right to health. And so our ability to be committed to being anti-imperial, being anti-racist, being anti-colonial, being anti-genocide is absolutely important. And so any conversation that's talking about equity or justice or resilience, but ignores the fact that we live, many of us, within these very challenging systems with compounded impact, are still going to fail. With health and care workers, here's what's important, is that we do have health and care workers who have disproportionate impact, right, from just compounding forms of discrimination, who have historically been made vulnerable. And we know that as a Black woman clinician right now, if I had to walk into a hospital, in any European hospital, there is that bias to say, well, is she actually a good enough medic? Is she a good enough physician? Right? And I often tell of the story when I was in community service back in my home country, where someone said, but I'm waiting for the doctor, right? Not you, but the doctor. And so those discriminations, people call them microaggressions. Well, for the person experiencing them, there's nothing micro about that. Okay? So we need to think about the ways that, therefore, a queer healthcare provider, right, the challenges of everyday work, if you're a foreign born or foreign qualified healthcare worker, what do those experiences mean in really what the word you really want to say is fascism, right? That's rising in this world. And therefore, those contexts of isolation, intimidation, career advancement barriers, unfair labor practices, unequal pay are not disconnected from what we often then call extractive capitalism. You have, and in closing, because you don't have time, just one final thought. You have a lot of African countries and those in the Latin American and Caribbean countries who already don't have so much money in their GDP, but they continue to put what they can in investing in training nurses and doctors. They qualify and they get poached to the global north, which is a global minority, with better packages, better rostering, better time off, and all of that. So what are we going to do about that? Because we do have a duty with each other, and global solidarity, by the way, under the right to health, it's an obligation of member states. It's not a nice to have. And by the way, so is international aid, no matter who says what. It is part of the right to health obligations. And so with global health aid in mind, with the brain drain, right, that's happening in these countries that already cannot afford. They can barely afford to pay the big, debt that they have historically. What does it mean then to continue to look at health and care workers as defenders of the right to health, who themselves are experiencing compounded challenges, both in their social lives at home, but also in the workplace? I'll leave it here. Thank you so much.
Fantastic. Thank you very much, Dr. T. And I think that's a very important lens and perspective, also because there's often a direct vilification of, healthcare workers and less consideration of how they have that role as defenders of the right to health and how they may be impacted. Thank you for that. I will quickly move us to Umira, who is joining us online virtually. And Umira will be focusing a bit around just engaging in civil society spaces and, how we've worked within the Human Rights Council with CSW and the work of AWID. But how are these shrinking civic spaces and anti-rights movement currently reshaping feminist and human rights organizing globally, particularly in relation to health, reproductive justice, and bodily autonomy? And on the back of that, what strategies have proven most effective in sustaining and protecting feminist and human rights movements under increasing political and legal pressure? Over to you.
Thank you. First of all, thank you so much for the invitation. And I think a lot has already been said by the two panelists earlier, so I'll try to keep it as short as possible. I think when we're talking about the global civic space and also anti-rights movements, I think we still need to connect it to the trends on the ground. And I think we also need to look at the bigger context of increased surveillance and crackdown on dissent, how it ties into the kind of intensified ethno-nationalism, conservatism that we're seeing, and also the impact of decades of neoliberal economic policies that have defunded public services for wholesale. One thing that we're seeing from our partners on the ground is the use of specific laws that are rising, especially foreign agent laws and also counterterrorism laws that has a chilling effect on dissent, not only for those working on civil political rights specifically, but also feminist organizing. And this really impacts what feminists feel they can say, they can do, they can document. Feminists working on abortion access, on the rights of queer people, on land rights, are increasingly becoming targets at the national level, thus also impacting their ability to participate in international spaces. And at the same time, you're also seeing a surge of counterterrorism laws being used. I think last week we just saw the sentencing of four Palestinian Action activists who were charged initially for criminal damages, but then also included for the charges of terrorism. So I think what we're seeing here is a bigger kind of crackdown, both in both the global north and global south, that has a direct impact on how feminists can do their work, how they can respond. And what we're seeing is really a lot of organizing being pushed into a more legal defense mode. And also, while we see movements still organizing for transformation, the access to be able to do that locally and also globally is really being challenged. And I also wanted to say that underlying all of this, and I think Dr. T has mentioned that, is the intensification of ethno-nationalism and nationalism locally and globally, that has really perceived or portrayed feminist organizing as a threat to the nation, the family, its local culture. So on one side, we see in many instances that gender, race, caste have become a political pawn. And in some cases, gender equality, bodily autonomy are presented as a threat to the sovereignty of at the national level. In other instances, we see gender equality become an imperial tool to justify violence against the less civilized. So I think within this context, we're seeing that feminist movements are seeing the need to connect the struggles more, to also organize transnationally, to make sure that all the issues that we're talking about are connected. And one part of this is also the need to connect the kind of backlash that we're seeing to the deep economic inequalities globally, and looking at specifically, and I think a lot of feminists have done work on this and have documented this, how the inequitable financial system has led to the severe defunding of health systems. For example, when it comes to debt, austerity measures, we see SRHR services being deprioritized, and this then leads to the burden onto feminist organizations nationally. And so one of AWID's report, Where is the Money, looks at how feminist movements are increasingly being under-resourced, and they're asked to basically fill the gaps left by a lot of these austerity and privatization measures, while also at the same being criminalized, defunded, and also administratively stifled. At the same time, the economic insecurity created by these neoliberal structures also drive authoritarian actors and also conservative actors. Feminists have highlighted time and time again that usually sexual rights and also rights related to gender are the first to be sacrificed, as outside framings and also regressive gender ideologies and scapegoating of marginalized communities, whether it's refugees, migrants, or queer people, are used easily as a tool of populist control. And so I think at the global level, we see this play out in multiple spaces like CSW, for example. I was talking to my colleague today, and she was telling me how at CSW 70, not the final text was adopted to a vote, rather the consensus. And I think this kind of shows how the big divide that we're seeing globally. And also, I was talking to my other colleague earlier that how leading up to the current HLM on HIV, which is happening next week in New York, states tried to remove the reference to key populations and also greatly limit the engagement of civil society. So I think a lot of what we're seeing globally is interconnected with the trends that we're seeing nationally. And and one thing that I also, because of time, I wanted to take away is that although feminist movements are leading the kind of responses nationally, I think transnational solidarity is still a very key component when it comes to regional networks, when it comes to feminist organizing. And at the end of the day, it still relies on states to meet their obligations, through making sure that, as Dr. T mentioned, that they do not export harm, they stop the harms that they are doing outside of their countries, but also making sure that that the aid that they are providing is not through conditionalities. One other thing that I also wanted to highlight before I close is that one thing that we're also seeing is the need to connect bodily autonomy with development justice more strongly, and we're seeing all these calls, and like a lot of feminist organizations are doing this. And so I think I'll just stop there just for time, and I'll pass it on. Thank you.
Thank you so much. Thank you, Amira. Very, very insightful. And I think I'm just drawing a bit on what you mentioned around the threats of the nation. That kind of framing attached with, family values and protecting the children, very deliberate efforts to kind of create harm by framing it through the lens of protection. Thank you so much. I will now slide us to where we think the money is. Alexandrina, I think there's also been a journey with the Global Fund. We've had the replenishment, we've got GC8, and there's just been a lot that's had to be navigated, even amongst the US cuts, the funding cuts overall. So for you, it's just to understand how the Global Fund is currently integrating human rights into its health investment, and where you see the most significant gaps or opportunities for strengthening that approach. And next to that, maybe concrete opportunities that exist for the sustainability of programs to reduce rights-related barriers. Over to you. Thanks.
Thank you so much. I think actually Kelsey has done such a wonderful job outlining why Global Fund is integrated programs to reduce human rights related barriers and its health responses, because without such programs, we are not going to be able to reach people with the life-saving services that they need. So the Global Fund to fight AIDS, TB, and malaria, for those of you that do not know us too well, is premised on ensuring that the right to health is central to the work that we do. It's premised on ensuring that people have access to the life-saving services that we fund. And this is why we have been investing in programs to reduce human rights-related barriers over time. As of 2017, our Breaking Down Barriers initiative has provided a proof of concept that shows that systematic effort over time, using catalytic investments, matching funds to catalyze greater investment, greater focus, greater country ownership, but also coming with some conditionalities to be able to access that additional catalytic funding, creating mechanisms for coordinated engagement, creating mechanisms for engagement of communities, creating mechanisms for elevating the voices of communities have proven to be impactful and effective in reducing human rights-related barriers to services. For example, we've seen that community-led monitoring of human rights violations, not just stopping and generating the evidence, but also using that evidence, very much in line with what Kelsey was saying earlier, using the evidence to inform programs, referring people to support and care, referring people to redress, referring people to low-threshold support, such as community paralegals. Again, going back to that value of community-led responses has been absolutely imperative in terms of ensuring that we navigate all those barriers and we help people have access to the life-saving services they deserve. Dr. T has raised the importance of ensuring safety and security for the providers of health services, not only the users of health services. And this is also something that Global Fund has been investing in. Safety, security, mitigating the impact of human rights crisis on our grants has been absolutely core, because otherwise we cannot make sure that the health services don't just remain available, but are accessible and acceptable and of good quality, very much the attributes of the right to health. So Grant Cycle 8 and the opportunities that it raises. Grant Cycle 8 country dialogues are happening as we speak. Some of you, I know, are engaged in those national coordination mechanisms, are engaged in those country dialogues. Please do engage, because that's where the opportunities lie. Please make sure that your voices are elevated and heard. We have minimum key performance indicators at the Global Fund, but look at whether you're engaged. We have key performance indicators around removing human rights-related barriers to services, keeping us accountable. So please engage, please use those opportunities, and please hold us accountable. Please make sure that national level decisions in terms of how to prioritize take into account that without removing human rights-related barriers to services, we're just not effective. We hear a lot of buzzwords these days. Integration, sustainability, they're very much buzzwords. Integration will only deliver if it makes sense for the people, if it works for the people. So such integrated services, if they are people-centered, if those integrated services are of good quality, if they can be reached, and fear is not driving people away from those integrated services, only in that case we can speak about effective and sort of self-reliant health programs. When we talk about sustainability of programs to reduce human rights-related barriers, surprise, surprise, a recent rapid assessment has shown that they are over-reliant on Global Fund funding and other international funding. It's a matter of survival these days. International funding is drying up. There is less and less international funding. So how do we use those national obligations? Because member states have taken them upon themselves by signing international treaties. How do we leverage national human rights institutions and also hold them accountable, not to forget about the right to health? Because there is a lot of focus on political and civil rights and not so much on economic, cultural, and social rights. But they are indivisible. They don't work one without the other. We've heard from multiple panelists today about how the shrinking civic space, how foreign agents laws, how counterterrorism laws are used to disrupt access to health. Right to health does not happen in isolation from all that. So bottom line, we've heard about the importance of interconnectedness. It's really important that we stay connected. It's really important that we work together, that we use whatever entry point we have, and we have to be innovative. The anti-rights movement is strong. The anti-rights movement is very united, so we have to be strong and united. We have to think about how do we use what exists out there in terms of national systems and national entry points, in terms of country dialogues for global fund processes, to make sure that we serve as the need to invest in programs to reduce human rights related barriers, to make sure that we serve as the need to invest in community-led responses, which have proven to be not only effective, but also resilient. So if we are talking about sustainability of HIV responses, sustainability of broader health responses, in the end, they only work and they are only sustainable if they are led by communities, if they serve the communities that need them most. So let's work together on that, because there is a lot of work to do.
Thank you very much, Alexandrina. So strong encouragement for us to engage in the national processes for GC8, but also I think the stronger conversation is around strengthening in domestic financing as well. I think this feeds strongly into building stronger health systems. Then I will now open the floor for some interventions and for you to engage colleagues. Patty, you can please check online. But maybe to start, I will ask our colleagues from the National Gay and Lesbian Human Rights Commission and Choice for Youth Sexuality to take the mic. Over to you. And please do introduce yourself.
Hi, my name is Lulu from the National Gay and Lesbian Human Rights Commission in Nairobi, Kenya. We work to ensure equality and non-discrimination for LGBTQ plus persons, and we do this through litigation, provision of legal aid and information, amongst other things. And I'm making this intervention on behalf of also Choice for Youth and Sexuality. I'd like to specifically point out the rise of anti-rights movements that have threatened that threatens to limit progress and roll back our hard-fought access to health, dignity, and justice in relation to diverse young human rights defenders. A recent report by IPAS and She Decides shows how anti-rights movement invests in young people to serve their political agendas by recruiting, funding, coordinating, and mobilizing them. Conservative youth networks are spearheading the global anti-rights movement, and in so doing, harming democratic and human rights framework, further impeding access to healthcare, dignity, and justice. We've seen the common going narratives of ex-LGBT who currently encourage conversion practices that have since been used to harm queer human rights defenders. It is often young human rights defenders, including young LGBTQ plus persons, young migrants, young sex workers who work at the front lines of advocating for access to health, and yet the ones who are facing growing hostility, shrinking civic space, disinformation campaigns, and restrictions that undermine both their safety and their work. Again, in a funding climate that is really difficult for youth-led organizations to navigate, with complex donor requirements and mostly short-term project-based funding, the deep funding cuts and shrinking civic space hit youth-led organizations the hardest, with many having to scale down or completely close their doors completely. And with closure, young queer defenders and the community at large have no access to products or information or legal aid as well, infringing on the right to health and justice. And as we've seen the increasing anti-rights movements and gender in the region, which are coordinated and well-resourced, governments, donors, and multilateral institutions must respond with equal commitment. This means funding mechanisms for specific for young human rights defenders, which are flexible and earmarked, sustainable, and simplified, and also investing in youth and community-led organizations, protecting human rights defenders in all their diversity, again, to strengthen the civic space and ensuring that health responses are grounded in the needs of diverse young persons. And this would enhance the enjoyment of the right to health, dignity, and justice, and anchored in meaningful and inclusive community and youth participation. Thank you.
Thank you very much, Lulu. I think the point about conservative youth networks and the fact that the resource movement is really investing in that as well is actually one of the things that we don't actually address a lot, because we are focusing on really working with young people to strengthen their rights, forgetting that there's a whole entire flood or tsunami strategy, as they would refer to it, of actually working with young people to really strengthen the anti-rights movement and their actors. Do we have any other interventions, colleagues? We have 3 minutes, so please keep it to 30 seconds if you've got anything else to add. Patty, online? No questions. Yes. Thank you very much, colleagues. I think we are good to come to a very well-timed closure for our session. Should we take the risk of 10-second closing remarks? Maybe not. Let's take the risk. A quick 30 seconds from Alexandrina, Dr. T, Kelsey, and Umira, please.
Hold us accountable.
Yeah.
Hold funders accountable. Hold governments accountable. Use every entry point. You know what works, so make it work.
Thank you.
So, in a world, of course, full of the enjoyment of the right to health, it is important to talk about the role of health and care workers, and we must demand accountability from them. We must demand the highest levels of care from them, and we must use them as the credible experts that they are in the global health system. And so we must see the practice of medicine in itself as a tool for the promotion of dignity and also for the defense of human rights, and particularly the principles of non-discrimination, substantive equality, autonomy, and privacy as well. Thank you.
Okay, we have seen that community-led responses works. Evidence shows that. We believe and trust people will continue trusting that process, and not to separate health from protection for the defenders. Thank you.
Thank you. Umira, 20 seconds.
Thank you so much. I would say as well, just echoing what everybody is saying, that I think we need to connect our struggles and we have to keep on being steadfast in our demands and connecting all of our issues together. Thank you.
Wonderful. And from Frontline Aids, I will say, let us keep having these engagements, make these demands, and work collectively really to strengthen rights-based approaches to health systems, to justice, to dignity. Thank you so, so much for being here, colleagues.
Wow.